Thank you so much for joining. This is the Physicians for Reproductive Health Roundtable for providers of abortion care and their reactions as we think about the moment that we're in right now for abortion access and the reality that we're entering into as we consider what's at stake with the threat to Roe versus Wade. My name is Kelsey Rhodes. I use she, her pronouns, and I'm the interim director of Voice and Communications here at Physicians for Reproductive Health. Thank you for joining us 4 days before the 49th and very likely last anniversary of Roe versus Wade for our abortion provider roundtable. While this is really startling to say out loud, what should actually be startling is the fact that abortion and reproductive health care is already inaccessible for countless communities in the United States. Right now, abortion is already just a right by name in so many parts of our country. And so as we think to what's ahead, it's critical that we're centering the experiences of people who have abortions, people who are funding abortions, and people who provide abortions, which is really why we're here today. All right, so let's get started. I am extremely honored to have the president and CEO of Physicians for Reproductive Health and OBGYN and abortion provider in DC, Dr. Jamila Perritt, kick us off.
Hello, good afternoon to all of you, and thank you so much for joining us. It really is my honor to be here today and to share my perspectives, not only as the president and CEO of Physicians for Reproductive Health, where we galvanize the passion and experience of over 440 physician advocates, but as a physician and a longtime advocate and activist for reproductive health, rights, and justice myself. As Kelsey said, I'm a board certified obstetrician and gynecologist, and I provide reproductive health care, including abortion care in Washington, D.C. D.C. is not just where I provide care, it's also where I grew up. This is my community, the community that raised me and the community that made me. I trust and believe in the people I care for. I trust that they're making the healthcare decisions that are best for themselves and for their families. I trust that the patients I care for know their lives, their needs, and their hopes for the future best. And this is the central pillar in abortion care, because as abortion providers, we know that abortion is essential health care and that private medical decisions about pregnancy should be just that, private. They should never be used as bargaining chips in legislative debates or weaponized for political gain. But that is exactly what is happening today. It's an honor and a privilege to care for my community. But in order to care for them in a way that allows them to live the lives they are defining for themselves, people must continue to have the right to control their own bodies, build the families they choose, and decide their futures. When politicians seek to impose restrictions on abortion that are based on ideology, not science, not medicine, they put people's health and well-being at risk. Plain and simple, politicians misusing their power in ways that impacts people's health care is dangerous. They are actively harming communities by making it harder for people to get the care they need and preventing doctors like me from providing evidence-based, safe, essential care. Politics has no place in the deeply personal decisions people are making about their bodies. The unfortunate reality is that despite the protections provided by a legal framework like Roe, legality has never been enough to ensure true access to abortion care for everyone who wants or needs it. That could not be more apparent than in states that have steadily chipped away at abortion access over the past decade, forcing people to travel hundreds of miles, spending thousands of dollars to get the care that they need and deserve. The nightmare stories from many Texans are becoming increasingly common. Along with other providers, I regularly hear the stories of our colleagues in Texas working to care for their communities, but being required to turn people away. We hear about how people are being forced to leave their homes and communities to seek abortion care in Oklahoma, in New Mexico, in Louisiana, in New York. You will hear some of these stories today. And for every story we hear of a pregnant person who was able to leave Texas to get their abortion, there are many others who don't have the resources, the time, the support, or the ability to do so. Anti-abortion politicians have made barriers to abortion care insurmountable for many, especially Black, Brown, and Indigenous people of color, immigrants, young people, and those living on low incomes. People are being forced to remain pregnant against their will, and politicians who think they know better are the ones making decisions about people's families and about their futures. In a country that claims to value bodily autonomy and the concept of justice for all, I cannot think of a more blatant disregard for these tenets than that which is occurring now in many parts of the country. Regardless of the Supreme Court's upcoming decision, people will always need access to abortion care. And Congress should not wait for a ruling from the court to meaningfully protect and expand abortion access and to affirm the dignity and autonomy of all pregnant people. Lawmakers should finally codify Roe versus Wade by passing the Women's Health Protection Act and the EACH Act, which would end our country's discriminatory ban on public funding for abortion care. We must work tirelessly to support the work of states working to codify abortion protections into their state constitutions and to fight back against states harming their people by restricting it. At this crucial moment in the fight for equitable abortion access, there is no time more critical than now to take bold action in defense of reproductive health and autonomy. We cannot simply accept the future that is before us, where people are unable to obtain the healthcare that they need. As you write and tell the story of abortion in 2022 and beyond, please listen to and center the expertise of people who have abortions and those who provide them. We must honor these stories of love, of advocacy, and of our collective work to build a future centered in equity and true access to abortion care. Thank you.
Thank you so much, Dr. Perritt. Thank you for sharing your experiences, your expertise. I'm now happy to introduce our next panelist, Dr. Bhavik Kumar. Dr. Kumar is the medical director for primary and trans care with Planned Parenthood Gulf Coast and is a board member with Physicians for Reproductive Health.
Thank you, Kelsey. Thank you, Dr. Perritt. Thank you all for attending, and thank you to Physicians for the invitation to speak today as we near the 49th anniversary of the Roe decision. I use he, him pronouns, and I've been providing abortion care in Texas for almost 7 years now, and I've witnessed law after law and regulation after regulation and so much more chip away at people's ability to access care in this state. Today marks 140 days of living and providing care under Senate Bill 8, or SB 8, which is the nation's harshest abortion restriction. SB 8 bans abortion once we can detect cardiac motion on an ultrasound screen on the second day that a person must present to access care under state law. And in my experience, this is meant as early as 5 weeks and a few days after someone's last menstrual period, only about 10 days after someone might have missed their period. This means that people have to verify that they're pregnant, make the decision to not be pregnant, consulting anyone they may choose to involve in that decision, if anyone at all, find a health center that provides this care, which has been greatly reduced in number over the past few years due to restrictive laws. They have to avoid deceptive crisis pregnancy centers, which have multiplied exponentially throughout the state, and then navigate the gauntlet of restrictive laws that have already existed in the state, including a mandatory 24-hour delay and bans on using any type of health insurance to pay for this care, meaning that people need to find the financial resources needed to cover the cost of their care within this limited window of time. Luckily, some people in Texas have managed to get the care that they need under SB 8 within the state. This is thanks to so many people here on the ground showing up despite the emotional toll that it takes on each of us to do our jobs under these unjust laws. There are so many nurses, surgical techs, medical assistants, people answering phone calls from patients, folks volunteering their time at abortion funds and practical support orgs, and so many others helping people get the care that they need closer to home. And while so many of my patients have been thankful for the care they've been able to receive under the harsh reality of SB 8, I know that they deserve better. They deserve all the time they need to make their decision. They deserve all the options that science shows are safe and effective. They deserve to be fully supported and comforted. They deserve respect. They deserve access to care that is fully supported by the state and free of shame and stigma that anti-abortion politicians continue to inflict upon them. And of course, banning abortion does not change the need for access to abortion, which has meant many people living in Texas have been forced to travel to other states to access care. As a physician, telling someone that you aren't legally able to do something in their best interest has felt unethical and traumatic for all involved. I've seen patients show determination and strength in these moments, while also witnessing audible wailing and begging for help. People have had to navigate waiting several weeks for appointments in other states, reaching a clinic hundreds of miles away and finding out that their appointment has been rescheduled. And they are often navigating a comparable gauntlet of abortion restrictions in those states, including mandatory delays and 2-visit requirements in many nearby states to Texas. Knowing that the Supreme Court of the United States has entertained upholding an abortion restriction in Mississippi and the Jackson Women's Health Organization case has put into play activating abortion bans in 26 states with trigger laws. When it comes to traumatic assaults on abortion access, what happens in Texas doesn't stay in Texas. A near complete ban on abortion in Texas has already harmed clinics in other states who are still trying to take care of the people that they usually would. Multiplying that over 26 states could potentially be devastating for so many people. We know that those with means will always have access to this care, but those who have been most harmed by abortion restrictions will continue to bear the greatest burden, namely low-income people and people of color, particularly Black people. We also see rises in maternal morbidity and maternal mortality again and again. Black women will bear the brunt of this trauma. So as we move through this landscape of abortion access in 2022, it's imperative that we center those who are most harmed by bans on access to abortion. For those of us with the power and privilege to share stories and information, I'd encourage you to move away from the typical dichotomous framing on abortion. We know that the vast majority of Americans support access to abortion, but it's extremist politicians who have made abortion political. They've used disinformation to promote their agenda and ignored science, like the Turnaway study, to uphold and further control marginalized people. The similarities between the COVID-19 pandemic and abortion access are difficult to ignore. And both, there are not two equal sides. There's just one just and humane side, and then the other that perpetuates harm. Thank you.
Thank you so much, Dr. Kumar. I am now honored to hand it over to Kieran Cobb, Director of Nursing at Trust Women, whose independent clinics are in Kansas and Oklahoma.
Hi, everyone. Thank you for having me here. I've been in the movement for more than 10 years now, and the threat of political restriction is always over our heads. Working for a clinic that has absorbed some of the Texas patient volume, we see the impact on these patients directly. Folks are scraping together what they can, and abortion funds are trying to fill in the gaps in both procedure cost and practical support, like food, gas, and hotel rooms. We know that wealthy white women will always have access to abortion, while these laws continue to systematically disenfranchise folks outside these demographics. For those that do make it to us here in Oklahoma, they come in further along in their pregnancies, which makes procedures riskier. This highlights that, of course, these political measures are not truly enacted in the name of patient health and safety. Being forced to delay care, having an abortion further into their pregnancy, having their abortion and then traveling 6, 8, 10 hours back home is a burden on patients and on providers. These restrictions are also straining clinic staff. It's difficult to find and retain staff. The job is easy, but the work is hard. We face barriers to providing care as well. Staff are faced with hostility and harassment daily from clinic protesters, politicians, and sometimes from our own communities. We're expected to do this difficult work under hostile conditions for too low wages because of our commitment to a mission. And we are committed, but we're also tired. Waiting for the next law that will put us out of a job is a constant stressor. Independent clinics in particular are doing their best to keep up with ever-changing legislation and keep their clinics afloat, which prevents us from expanding services. Spending the money to keep our clinics open and up to date with the state regulations has limited our ability to provide other vital services like gynecologic, family planning, and gender-affirming care. We just don't have the physical, monetary, or staffing capacity to provide any other services than abortion right now. And this is another tactic used to limit abortion access to exhaust the providers. Working in abortion care is what inspired me to become a nurse, and I'm hoping to pursue my advanced practice degree to provide abortions. But this isn't possible here in Oklahoma or in most other states. It's an ongoing struggle to grant mid-level practitioners authority to work within their scope and skill set across all of healthcare. Providing both medication and surgical or procedural abortion is well within the abilities of midwives, nurse practitioners, and physician assistants. Again, these restrictions are passed under the guise of patient safety, yet they explicitly keep patients from seeing competent providers. These restrictions are imposed on procedures that are generally safer than colonoscopies. Fewer adverse medication effects come from medication abortions than come from Tylenol. Yet arbitrary, medically inaccurate barriers to when, where, how, and by whom abortions are performed exist in nearly every state. This burdens doctors and patients with increased patient volume, wait times, and risk. Even in most progressive states, they have imposed restrictions on the ability of mid-level practitioners to do abortions. These are elitist policies that implicitly restrict who can do abortions to those who have had the resources to go to medical school. In the Midwest, we cover such a large geographic area that patients must travel hours to get to us, not to mention those coming from other states. Mid-level providers and telehealth can and should be used to fill this gap. COVID-19 has highlighted the necessity and possibilities of telehealth to expand access to all types of healthcare, including abortion. Medication abortion can be and is being done safely over telehealth. Increased access to more providers, methods only improves patient experience and outcomes. Passing pro-abortion legislation like the EACH Act would allow many patients to access healthcare they need. Having coverage for their abortion means the difference between making rent or being evicted this month for some patients. No area of healthcare is restricted the way that abortion care is, and no other providers have to jump through the absurd hoops that abortion providers must. They're forced to tell patients, at best, medically unnecessary, and at worst, medically inaccurate information. The moral injury to providers and the actual patient harm this causes must be addressed by legislation like the EACH Act and the WHPA. Restrictions like Hyde and so many others underscore the racism and classism in healthcare and the legal system. These bans obviously impact BIPOC far more than white people. Restrictions on access to healthcare in general, and specifically family planning, disproportionately affect people of color and people in poverty, making them more likely to need abortion care as a result. When we talk about Hyde, we must remember the people it harmed, like Rosie Jimenez, who died as a result of the restrictions Hyde imposed. Legal action is always looming, but we're here and we keep doing the work despite and in spite of it. Thank you.
Thank you, Kiernan. Thank you so much. And last but not least, I am going to introduce Dr. Aisha Latunde. Dr. Latunde is an OBGYN in Philadelphia and fellow with Physicians for Reproductive Health.
Hi, everyone, and thank you so much for inviting me to speak here today alongside such inspiring providers. While I just recently completed my training as an OBGYN specializing in comprehensive reproductive health care, including abortion care, I've already seen the tale of where you live being a predeterminant of the kind of health care you had access to, as I've trained and worked now in both Seattle, Washington, and Philadelphia, Pennsylvania. I didn't realize how drastically more accessible abortion care is in Seattle until I moved here to Philadelphia. I knew my work would be challenging, helping people navigate medically unnecessary hurdles to get the care they needed, but I'm losing count on the number of hoops patients have to jump through every day to get an abortion. Throughout my medical training, I ignorantly believed each Roe v. Wade anniversary was solely a celebration, recognizing a landmark decision that protected a person's right to an abortion. But this anniversary, I realized how naive that thinking was. I'm still pretty early in my career, but the existential crisis is very real. As the anniversary of Roe v. Wade approaches, all I can think about is the overt disregard for pregnant people's bodily autonomy that already exists and how it will be exacerbated in catastrophic ways if Roe is overturned. Even in the presence of Roe, the patients I care for are seen as incapable and unable to make decisions about their body without government interference. And this couldn't be further from the truth, and it's a direct extension of white supremacy's reach to control and harm people, especially Black and Brown communities. I think about all the things I could do as a physician providing abortion care in Washington state that I now have to think twice about here in Pennsylvania. I'm required to order unnecessary tests on patients that have no clinical bearing on the safety of their abortion. Patients must wait 24 hours after I read the most ridiculous state-mandated script filled with lies before patients receive their abortion as a part of the consenting process. Part of that script is informing them that the father of the baby is required to pay child support if they decide to continue the pregnancy. Patients wait up on hold for up to an hour to connect with local and national abortion fund organizations to help them pay for their abortion because Pennsylvania Medicaid only covers it in cases of rape, incest, or threat to life. This strips the patients I care for of their dignity and is just plain insulting. The coercion to try and push people to second guess what they already know is right for them and their families isn't just belittling, but it's dangerous as well. Even some of my colleagues bear the burden of restrictive abortion policies. The nurse practitioner in my clinic can administer mifepristone and misoprostol and perform uterine aspiration procedures when managing a patient with a miscarriage, but they're forbidden from doing the exact same things for patients seeking abortion care. The only difference is the stigma and medically unnecessary restrictions placed on abortion care to push it further and further out of reach. Now, I've recognized that there are restrictions like this in states all over the country, and in some places it's much worse, which is why Pennsylvania is frequently not seen as a place of concern when it comes to abortion access. With no trigger law in place in Pennsylvania, abortion as it currently stands will stay the same in the event of Roe being overturned. But it still feels pretty precarious here in Pennsylvania. With a state legislature seemingly obsessed with restricting abortion, it constantly feels like we're teetering on the brink. In the last 5 years, they've tried to limit abortion to 20 weeks and ban abortion for certain prenatal diagnoses. Most recently, the Pennsylvania House just passed a bill that would require all fetal remains to be buried or cremated, regardless of gestational age and regardless of if remains came from an abortion or miscarriage. Our only line of defense right now is our governor using his veto power, but we shouldn't have to put the healthcare of our communities in the hands of one person's veto. If Roe is overturned and Pennsylvania continues to pass anti-abortion legislation, we will see sweeping overhaul of the abortion landscape. And access in central and western Pennsylvania will be especially limiting, being surrounded by states like West Virginia and Ohio, states who are already pushing pregnant people out of their communities and into clinic like mine, hours away because of unnecessary restrictions. So all of this leaves me in a constant state of worry for the patients I see every day. And not just the patients whose pregnancy won't survive due to a life-limiting anomaly, or the patients whose life is in medical danger if they continue their pregnancy. I worry about all of the patients I care for, the ones that say it wasn't the right time, the ones in harmful relationships, the ones who want to safely and fully parent the children they already have, and the ones that just don't want to be pregnant, period. All of their stories matter. Abortion shouldn't come with caveats. We don't need patients to prove their abortion is worthy of receiving. Abortion is healthcare, and people make all sorts of decisions regarding their healthcare all the time, and they should be able to do that when it comes to abortion. We have to respect and honor those decisions without question, without having to justify it to anyone, especially to government officials. It shouldn't depend on where they live, how much money they make, or who the governor is. We desperately need federal protections for abortion access and coverage without any strings attached. Thank you.
Thank you so much for sharing. And thank you to the rest of our panelists. Again, Dr. Jamila Perritt, Dr. Bhavik Kumar, Kieran Cobb, and last but not least, Dr. Aisha Latunde. Thank you for sharing your critical perspectives as we approach the 49th anniversary of Roe versus Wade. We're so grateful for your hard work and for your ongoing advocacy.